Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Brazil, Professor Antonio Aversa. Dr. Aversa is currently the chairman of neurosurgery section at the National Cancer Institute and coordinator of the skull-based surgery program at the Clementino Fraga Filho University Hospital at the Federal University of Rio de Janeiro. He has also been serving as secretary of the World Federation of Skull-Based Surgery Societies since 2022. After his board certification by the Brazilian Society of Neurosurgery, he did his fellowship in skull-based surgery at the Arkansas University under the mentorship of giants like Professor Al-Mafti, Professor Yasser Gill, and Professor Ali Christ. He is a reviewer for several scientific journals in the field of neurosurgery, and his clinical expertise lies in the field of microsurgery of the brain tumors, tumors of the skull base, cerebrovascular injuries, microneurosurgical anatomy, and endoscopy of skull base. We are extremely honored to have him today at our webinars, and today he will be talking about the subcranial approach to the anterior cranial fossa. The speaker for the second session of today is our honored guest from China, Professor Li Wen. Professor Wen is a specialist endovascular neurosurgeon at the Department of Neurosurgery and Brain and Nerve Research Laboratory, the first affiliated hospital of Suzhou University, Suzhou, Jiangsu Province, China. We are extremely grateful to him today at our webinars, and today he will be talking about endovascular management of cavernous sinus DAVF. The chair for the first session of today's webinar is our honored guest from Jordan, Professor Ibrahim Sabah. Professor Sabah is a consultant neurosurgeon at the Farah Healthcare Campus, Amman, Jordan. He is the past second vice president at large of the WFNS, and he is a member of various committees of the WFNS, namely the Skull-Based Surgery Committee, Education Committee, and Fundraising Committees. He was the past president of the Jordanian Neuroscience Society and the past president of the Pan-Arab Neurosurgical Society. He continues his educational initiatives for the young neurosurgeons through the weekly online Jordanian Grand Rounds in Neurosurgery. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honored guest from Japan, Professor Akio Hyodo. Professor Hyodo is a consultant endovascular neurosurgeon at the Tokyo Medical University, Saitama Medical Center, Saitama. He is a consultant for the Tokushakai Medical Group in Japan and is a specialist for cerebrovascular diseases who has published several manuscripts in various periodic journals. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liubun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Ibrahim Sabah.
Thank you, Raja, and my thanks extended to Professor Yoko Kato, Professor Ben, for inviting me to chair this session. Thank you again. My name is Ibrahim Sabah from Jordan, and whenever you mention the word Brazil, what comes to your mind is the beautiful cities of Brazil, Rio, Sao Paulo, other cities, the beautiful nature, the beautiful beaches and beautiful people there, and of course the carnivals of Brazil. And also you would immediately remember the football. This is Pelé, better known as Edison Arantes do Nascimento. I was fascinated by this man when I read his story. When Brazil lost in 1950 the World Cup, he cried and his father cried, and he promised his father that in 1958 he will get the Brazil the World Cup, and he did. Of course, Garrincha, Zico, Romario, Roberto, Rivaldo, Neymar, last but not least. And also you would remember how magnificent surgeons Brazil has produced, and I had the privilege and the honor to be a friend to many of them. This is my great friend Evandro de Oliveira, late Evandro. We lost him a couple of years ago. It was de Souza. Here we were traveling together to various places like Vietnam and Thailand and so on. And my dear friend Luis Borba, we are together members of the Candy. And the meeting that was held in Brazil in Porto de Galinhas, Recife, back in 2011. And here is a picture with the Yoko Kato there. And of course, Eldo Azevedo, my great friend in the World Federation, my great friend Apio Antonis, who hosted us in his hometown, and my friend Benedicto Colli from Brazil. And today we'll present you another great surgeon from Brazil, Dr. Antonio Aversa. Dr. Aversa was certified by Brazilian Society in 1996. He did skull-base surgery at the University of Arkansas with giants like Professor Yazarjil, Sam Al-Mifti, and Ali Christ, all of whom I have the privilege of knowing them and knowing them as great mentors and great friends, great colleagues. Dr. Aversa, reviewer of several scientific journals in the field of neurosurgery. He has been serving as Secretary of the World Federation of Skull-Based Societies since 2022, and he has experience in the field of microsurgery, brain tumors, skull-based tumors, cerebrovascular injuries, microsurgical anatomy, and endoscopy of skull base. This is some of the papers I could find on looking in the literature. Resection of skull-base meningiomas, repair of skull-base in Cavernous heel, Cavernous sinus meningiomas, and the radiation effect of these cases. The zygomatic approach for the cavernous sinus chordoma, transcranial approach to invasive giant pituitary adenomas, and total petrosectomy of total section of the sphenopetroclival meningiomas. Cranial orbital zygomatic approach for juvenile nasopharyngeal fibroma, ruptured dermoid cysts, and these are rare. Surgical strategy for intracranial dermoid and epidermoid. He is currently the chairman of the neurosurgery section at the National Cancer Institute in Rio de Janeiro since 2014, and he is currently also the chairman of the neurosurgery department there. Today, he is going to speak to us about the subcranial approach, a straightforward approach to the anterior fossa floor. It is my pleasure and honor to present to you Dr. Aversa. Dr. Aversa, the microphone is yours.
Oh, good morning and good evening to all of the colleagues of the Asian Society. It's a great honor for me to be here and discussing with you, learning from you, those teams that are passion for us, the skull-based surgery. So I would like to thank so much Professor Krishna Kanti, Professor Spade, for the nice invitation. It's really a great honor for me to be here. I would like to share with you what we have done in the last 25 years in my city when treating those anterior fossa tumors, malignant and benign tumors, and what our philosophy. And I would like to discuss with you what we have been doing since then. So thank you again for the kind invitation. It's a great honor to be here too. So this is my, thank you, Professor Bate, for the introduction, the kind introduction. This is, I cannot forget to mention my great mentor, Professor Mefti, and I had the opportunity, I was so lucky to be there at that time in Little Rock with Professor Yazagil, Professor Christ, and so wonderful colleagues of fellowship as Professor Turi, Professor Arnautovic, and Professor Sakata from Yokohama, great friends since then. So when you see those kinds of tumors, as you know, we have many options for approaching. Those are the traditional options, the COZ, bifrontal approach, traditional ones, the pteronal approach, and the subfrontal, and more recently, of course, the endonasal endoscopic approach. But when you are dealing with malignancies, I work in oncology institute, so we receive many patients from all over the country. It's a huge country, so we have a big number of this kind of pathology. We used to do in the past the traditional craniofacial approach with some modifications, and more recently we already are we are also doing endonasal endoscopic approaches, but I would like to share with you what we have been doing with this. This is a very interesting approach that unfortunately many people even didn't know this approach in our neurosurgical community all over the world. So I would like to spread the knowledge of this approach that is a simple one, is very effective for treating all of these pathologies. So we started our experience 25 years ago dealing with such huge tumors like this, with a large esthesioneuroblastoma. We were used to do this kind of surgery. Was a mid-facial translocation with the frontal and nasal osteotomy. We could made a transfacial approach for these tumors, and we were not used to do regular craniotomies as Ketchen showed in the past. So we could realize that even larger tumors in the anterior fossa we could approach through the frontal and the ethmoidal sinus, but with these facial incisions and mid-facial translocation. But we could reach and treat those patients and even larger extensions of the tumor in the anterior fossa through the frontal and ethmoidal sinus. This is another example, young male also, with large esthesioneuroblastoma, the same. It was very effective in terms of oncology resection with free margins, dealing those pathologies in this way, with this mid-facial translocation, with a very good reconstruction also. And this is the results. You see in late results with a very good control of the pathology. Those are low-grade malignancies, but they are malignant tumors, but we could treat them, many of them can be cured in this way. But we still have the problems of the facial scars. Even with a very good reconstruction, functional reconstruction, we still have the scars. So we changed our mind about 15 years ago and started to do this approach. Was developed by a Swiss head and neck surgeon, Professor Havet, in the late 70s and 80s, and has been using for a few pathologies in the head and neck area. And this is the publication that Professor Spate mentioned, that it was just published in the operative neurosurgery in the master series section. So this is a relevant anatomy of this approach. It's very important to know the canthal ligaments. We are used to perform the osteotomies just above the canthal ligaments. And then can you see when you do from these dissections of Professor Houghton, how beautiful is the anatomy of the anterior fossa? So these are the essential steps. We can realize the dimensions of the frontal sinus with transillumination with the endoscope, and we can use also the navigation for performing this osteotomy. We use the oscillating saw, so we can see the limits of the frontal sinus and perform the frontal nasal osteotomy. After drilling the posterior wall, we can reach the ethmoidal arteries, and then resection of the tumor first in the nasal cavity and paranasal sinus, getting the free margins from the resection, nasal septum. We can reach the nasopharynx in this way. So we move to see from below the anterior fossa, ligating the superior sagittal sinus, and then cutting the falx. We create space for pushing these tumors downwardly, so we have more space for work without even touching the frontal lobes. So we can work like we are operating a convex meningioma and then performing microsurgical resection of the limits in arachnoid, then detaching the dura of the anterior fossa, taking all of the compromised bone, even to the sphenoid plane. And then that's the biggest difference between this approach and the endoscopy. We can perform a watertight closure of the big defects in the dura of the anterior fossa. So it keeps the same principles of Almefti's Professor Almefti COZ. So the COZ is designed for a lateral approach to anterior fossa, but coming from below. And this is for the midline pathologies. And it keeps also the same principles of Dolenk's of extradural resection of the anterior clinoid. We can do the same with the crista galli, performing extradural resection. And then when you do that, it's a kind of open the gate, so we can unlock all the anterior fossa in the nasal cavity. These are a few examples how when you do the, this is a case that I did last week, how we perform the drilling and resection extradural, the crista galli for unlocking the anterior fossa for a kind of pathology like this is a recurrent sarcoma. Let me start the video. So we try to resect on block, drilling the bone around, dissecting the soft tissues, planes around the tumor, and then cut the bone around. And then you see how we can dissect the crista galli extradurally, drilling the base of the crista galli, then taking extradurally the crista galli. We unlocks all the anterior fossa and the nasal cavity, so we can work and deal with the dura, involved dura in the anterior fossa, taking the limits of the tumor, going around the tumor, and then perform a total unblock resection lesion. And then we have plenty of space for reconstruction with temporal fascia and in a watertight way, even preserving the contralateral olfactory groove. So this is reconstruction with the outer table coming harvest from the parietal bone. So we can perform a reconstruction with autologous bone. So this is another example of a stissionero. Then we can resect one olfactory groove, preserving the other one. After unlocking the anterior fossa, taking out the crista galli extradurally, this is a vision coming from below with the endoscope assistance. So we do this surgery with endoscope assistance. It's very useful endoscopy in this approach, but most of the work we do directly in a straightforward way, coming from the frontal ethmoidal sinus. So this is post-op with a very good, cosmetic result also. We started with those small stissioneuroblastomas, like this one. We know that the activity, the surgical activity is very different, even in the same country, but we can do this in a very simple way, performing, fixing the osteotomy, even with nylon sutures after that. If you don't have in poor countries the opportunity to fix with the mini plates, and we can put back the bone. It is very simple to fix that because it is a very small osteotomy. Then you can fix very well. So as in this way. So this is another example of stissionero with not so big extension in the anterior fossa. This is post-op with reconstruction with the fascia and also with the pericranial flap. So this is another example, was a doctor with neuroendocrine carcinoma. In this, since the beginning, this is the bicoronal flap, and then detaching the pericranial flap, detaching the supraorbital nerves. And then we can use also this tool is very useful tool, is the bone scalpel for performing the osteotomy of the frontal sinus and nasal bone. It's very simple to do this, very quick procedure. With the scissors, we detach the bone flap. Then we take off the mucosa, and after taking the mucosa, we drill the posterior wall of the frontal sinus. This is the crista frontalis interna, taking the orbital roof, and then taking extradurally you see the crista galli. So it unlocks the anterior fossa. After resecting the nasal cavity component of the tumor, we ligate very anteriorly the sagittal sinus. This is the view from below, as you can see, and cut the dura around the tumor. We can take the tumor, infiltrating the frontal lobes. So cutting the falx and then resecting all the infiltrated dura with free margins. Then we have this gap in the dura that we put the temporal fascia, and then we can perform a watertight closure. This is the biggest difference between this approach and the endonasal approach, because you can do a real good closure of the defects, and we can deal with all kinds of tumors, even the bigger tumors, taking the advantages of the craniotomies. So this is the result, the osteotomies in the CT, and then this is the MRI and the PET scan in the post-op. This is another case, a big one, with a young girl. This is the post-op. This was wrong diagnosed as esthesioneural, but was a lymphoma, was totally resected also, with a very good cosmetic result always. And even if you are doing really osteotomy in the face, the reconstruction is so easy and the cosmetic result is so good. And this is a recurrent tumor, was a adenocarcinoma. In this way, we perform an en bloc resection of the whole ethmoid. And then we didn't have, because was used in the past, the pericranial flap. So we took the pericranial flap pediculated in the frontal, in the temporal muscle, and with a small window, we put this vascularized flap for reconstruction the anterior fossa in this particular case. Even those larger tumors like this one, when you have infiltration of the nasal bone, we can take this. Is completely impossible to do this through endoscopy, of course, because you don't have the angles, and it is impossible to deal with this bone infiltration. Like in this case, this is not so uncommon in malignant cases. So we can reconstruct harvesting bone from the parietal area, outer label. You can perform a reconstruction of the nose, as you can see here. And this is another case. Large esthesioneural also was operated in another institution with a small resection. Then we can do a very good resection through this way. And those esthesioneuros, we can even treat and cure many of them with radical resection, and then radiotherapy, of course. This is a neuroendocrine carcinoma, also with a huge extension to the anterior fossa. Is also a perfect case for this kind of subcranial approach. This is post-op. This is another case, adenoid cyst carcinoma. I had operated many years ago, 2011, and he had a recurrence. This is 2017, was still okay. And then he had a recurrence almost 10 years later. And then we did, through the same approach, resection of these recurrent tumors, and he's still doing well. Then we started to do this for benign pathology also. This is a rare case. This is the only case I have of olfactory schwannoma. It's a rare pathology, but it's a perfect case also for this kind of approach, a very simple way to do this. Then we start to do this. One of my passions also are the meningiomas of the anterior fossa. And then we start to do this in the olfactory groove meningiomas. As Professor Omefti teaches, almost 1/3 of those patients had infiltration, really infiltration, and of the bone of the anterior fossa. Then when you are more radical dealing with this compromise of the bone in the anterior fossa, you can reach a better result, a long-term result of this pathology. Then we start with the smaller ones, and then even bigger ones like this one with calcification, we can deal with this kind of approach. This was easy because it has a large frontal sinus, but even with a smaller frontal sinus, we can do the same because we can came from below. And believe me, when you are dealing with this kind of pathology through the frontal sinus and ethmoid, you feel that you are operating a convexity meningioma. You even doesn't touch the frontal lobes. You can see the tumor since the beginning. This is another example. Is a perfect case for coming from below in the subcranial approach. And then this is the osteotomy. We make transillumination with the endoscope that is in the operate room. So we only touch the bone, then you can see the limits. But of course, if you have the navigation, we can mark where is going to be the osteotomy for performing the frontonasal osteotomy for dealing with this kind of tumors. So the reconstruction, even with nylon sutures, you can fix it very well, the bone after the procedure, at the end of the procedure. And believe me, this is the biggest difference. These patients go much better in the post-op without any problems, in cognition, because you don't touch the frontal lobes. You see, you don't have any kind of retraction injury in these patients. So this is a perfect case for this approach, because it's already involving in a bad way all ethmoid. Then we can do a direct approach through the subcranial approach with those very invasive tumors in the nasal cavity. So I think this is the last case I'm going to share with you. This was a very difficult case because this guy had retinoblastoma at a young childhood, and he had already lost his vision the right side, and he's losing his single vision the left side because of this reduced meningioma that was growing to the anterior fossa and grow to the left orbit and ethmoid and nasal cavity. So we must preserve his vision this side. And this is a perfect case for coming from below. So this is the video after performing the osteotomy, drilling the posterior wall of the frontal sinus, and then dealing with the tumor and in ethmoid. This is Crista Galli here. And then taking the tumor from ethmoid, this left orbit and right orbit, and then opening the dura. You see from below, you can even see the brain. You came from below, from ethmoid, and then taking the tumor in a piecemeal way, using the CUSA also. You are not touching the frontal lobes. You see, coming from below, you have plenty of space, and then pushing the tumor downwardly, we create space for dealing with the tumor and then dissecting from the frontal lobes. You see, it's like you are operating a convexity meningioma. And then using the tool, this tool, the CUSA for, and then taking the lamina papyracea, infiltrated, then periorbit, of course, and decompressing the orbit. And then we can perform a watertight closure using the temporal fascia. And then after that, rotating the pericranial flap for reinforcing the reconstruction of the anterior fossa dura. So this is pre and post. You see any kind of retraction of the frontal lobes, we can perform a radical resection. It's been almost 8 years, this surgery, without any recurrence in this particular case, in this difficult case. So those are my numbers. I have many more patients that I did before in the regular craniotomies, of course, but these are my numbers with the subcranial approach in the last almost 15 years. I had 3 CSF leaks. Most of them were radiated before. This is a concern when you have not such a good tissue for radiated tissue. We had a partial reabsorption of the bone flap after radiation. And then when you detach the canthal ligaments, if you do not fix them, we can have the telecanthus, and we had in a few cases patients that died of correlated pathology comorbidities. So in conclusion, we can use the subcranial approach, take the advantages of the craniotomies as we are used to do, and take the advantages of the endoscopy also. With a very inferior angle of view, no frontal lobes retraction, but the biggest difference between the subcranial approach and the endoscopy that we have a very, very low incidence of CSF leak. So this is a subcranial approach, is a direct inferior approach to the anterior fossa, to the whole cavities, nasal cavity and perinatal sinus, with extradural resection of the crista galli, unlocking the anterior fossa. This is a very important step of the procedure. In some cases, we can even preserve the smelling, and water triton reconstruction of those large dural defects reduces dramatically the incidence of CSF leak. So if you are thinking in dealing with this kind of pathologies as neurosurgeons or air endoscopic surgeons, you see, we started to work not together. We started to work together in the last 20 years, the ENT and the neurosurgeons, but we have different concepts, but we cannot be separated because of these concepts. I know only to do surgeries with craniotomies, and the other guys only to know to perform through the nose, but we can use the middle way as the Oriental philosophy teaches. So thank you very much for the kind invitation. It was an honor to me to be here, and I'm expecting your questions for discussion. Thank you so much.
Well, thank you very much, Dr. Avesa, for this enlightening lecture. Thank you for sharing with us your vast experience in this topic, which a lot of people don't know much about. I have a few questions for you, if I may. I see that the commonest pathology that you dealt with through this approach was the meningiomas, 27 meningiomas, 15 neurocesoplasmomas. Now, these giant meningiomas, olfactory group meningiomas, I think you showed the power of surgery here. I think you're sending a strong message to those who use radiosurgery to treat these cases. This is abuse of radiosurgery. These cases are for surgery and for radical excision. The patient has one chance, and this chance is to take the tumor completely out through whatever mean you have. So thank you for sending this strong message to those radiosurgeons who just treat everything and anything with radiosurgery. My question to you about the giant frontal sinus. What do you do with them? Sometimes they are really giant that you need to reconstruct. Do you use fat or what?
I think this is a nice question. We have these extremes, the large, very large frontal sinus and this very tiny also frontal sinus. We can do this approach in many situations. If you don't have frontal sinus in younger people, we can perform, a similar craniotomy outside what the limits of the frontal sinus. When you have a tiny frontal sinus, we can kind of enlarge of the frontal sinus, performing oblique osteotomies, so we can drill the posterior wall of the bone, and then we can enlarge a little bit more the frontal sinus. But when you deal with this large frontal sinus, I think it's much easier to do this kind of approach if you compare, for example, with those large bifrontal craniotomies. I have never doing these bifrontal craniotomies in the last 20 years, because if you have a problem and you see that we can sometimes have problems with infection and you lose a bifrontal flap, this is a nightmare for reconstruction, because if you put any not autologous material there, it can be infected in the future. So when you have those large tumors, of course, we can have some space. I'm using it to fill this space only with gel form, and it helps to press the pericranial flap against the dura, and avoids empty space there for infection. But if you have a real big space there, we can put also fat for filling this space. Thank you for the question, Professor Spade.
Thank you. Another question is, do you use lumbar drain routinely or do you just use it in certain cases?
No, no. As I showed you, we are performing watertight dural closure. So believe me, this is a very, very uncommon situation of CSF leak. So I don't think it's necessary. And in some cases, we are afraid of, we have pneumocephalus, and if you use the CSF lumbar drainage, I think you can increase this chance.
And you showed us that you are using endoscopy together with the subcranial approach. Do you use that routinely or again in certain cases?
Yes, I think endoscopy is, as you know, is a very useful tool. Is always in my operating room. We can both in the, I expose everything, so we can use the endoscope. I have the colleague, making the endoscopy assistant from below during the whole procedure. And even in some situations, it's easier to detach the tumor from the nasal septum coming from below with the endoscopy. But the great majority of resection coming from above.
Recently, there has been interest in going transcranially through the orbit. How do you feel about that? Transorbital approaches for cranial pathology.
Well, with this idea, I don't, this concept of keyhole or minimally invasive, I don't think, for example, I perform a bifrontal bicoronal incision. People never complain about this. They do this for plastic surgery. Don't think this is a major procedure. So this kind of, minimal invasive, you must have maximally effective. So I don't think it's necessary only work in a very small skin incision. I think and even this idea of, displacing the orbit content, I'm not feel comfortable to do that since now.
Any questions from our colleagues or from the audience?
Well, I'll ask one question. First of all, let me congratulate Professor Antonio Aversa and thank him for this wonderful lecture that he has given us. We are extremely grateful to him. And surprisingly, your surgeries were akin to what Professor Luis Borba usually says, that scalp surgery is like a robbery. You get into the bank, do not disturb anybody, just take out all the money you can and get out. So you haven't disturbed any frontal lobes and anything, you just did a super excision. Surprisingly, the infection rate was zero. What precautions do you take to have no infections in your surgery? Because this sinonasal cavity is a single thing, a common thing after you excise all the bones in between. So do you prolong your antibiotics, or it is the same routine as a normal craniotomy?
Oh, this is a very good question. We had not in the immediate post-op, a few cases we have, when you deal with paranasal sinus pathology, sometimes we can have sinusitis in the post-op, in the late post-op. But we do the same of the ENT guys do. We leave the patients with 2 weeks of post-op antibiotics. But I think the biggest difference in the lowest incidence of infection in this kind of craniotomies is that we are dealing only with the cortical bone. I think this is the biggest difference. When we perform a regular craniotomy, we have the whole bone and the cancellous bone. I think this increases a lot of the chance of the infection. So we had many more cases of infection in the past with those bifrontal craniotomies when you compare with this, because we only put a small piece of bone, of cortical bone back in. many of these patients had already, when we opened, there is a mucopiocelis, was a contaminated surgery. But we, of course, we clean a lot with saline and then leave the patient with 2 weeks of post-op antibiotics. And I think, if you treat these patients, even with infection in the post-op, and leave the bone, only the cortical bone, and you can treat this infection and don't have to take out the bone in the post-op. So losing the flap I hadn't had this is a lucky, but hadn't happened till now with this patient that I treated.
Well, thank you very much. Any questions from my co-host, Levun Singh?
Yeah, thanks, Professor, for very fascinating talk. I have 2 questions, Professor. First, regarding the use, I saw your initial surgery, you use oscillating saw. And then, is there any tips there to control the oscillating saw to avoid dura injury for initial part? Because once it's injured, it's very difficult to suture at the edges. My second question, Professor, if you're going to use craniotomy per se, will you do the initial, where do you do the initial bone opening? Do you do under the suborbital rim, so it's hidden? Because I don't see any opening of the bone for the initial cut for your wound. My second question, Professor, is regarding the bone absorption that you told us. So, in your opinion, if there's either bone absorption or infection, how do you going to repair the defect? Is there any means to repair by autologous or by other material, Professor? Thank you.
Thank you for the question. When you are not so comfortable using new tools, we have to train with those tools. And the oscillating saw are not, neurosurgeons are not so used to use this tool. But you have to take care of using, but it's a safer tool for using since you are a user to use. And we perform the osteotomy oblique in the direction of the frontal sinus. So it's not going to touch the dura. So even when you go perform the orbital ring resection, you can detaching the periorbital, and then we go from below of the orbital ring. So we never go in the direction of the dura. So this is one point. And if you use the bone scalpel, it's easier to do this because it's much safer. We don't have this kind of oscillation. When you use the saw, you have to protect the orbit so you can sleep with the tool, but you have always to protect the orbits. And the second question is about infection, isn't it?
And bone absorption. What replacement material is the best for the defect?
Actually, as I said, fortunately I didn't have to take out this cortical bone flap. But if you have a late infection of sinusitis, we can treat and leave the bone there. But even in this situation, with the bone is infiltrated, then you can take out the bone. I prefer to do reconstruction with autologous bone coming from the parietal outer table. And I think the only prosthesis for reconstruction of this area that I believe are those titanium not that you mold it, that you came from already molded, that you put there, because I think they are only the prostheses that you can, put in the contact with the frontal sinus, and you don't have a late infection.
And the computer-generated titanium mesh.
Yeah, I never use bone cement in this area, because if you use bone cement, you have 100% of chance of infection, late infection. So never use bone cement in the frontal sinus.
Thank you, Professor.
Well, thank you very much. So far, we do not have any questions from the attendees. So we'll go back to our chair, Professor Ibrahim Siba, to say the concluding remarks for this session.
Again, thank you very much, Dr. Belsa, for this very enlightening lecture. And I think, as I said, you sent strong messages regarding radiosurgery that people use for olfactory groove meningioma. Surgery is the first and the second and the third choice for the neurosurgeon to help the patient. Thank you again, and I hope we'll meet many times again.
Thank you so much, Professor. Thank you, all the colleagues.
Well, thank you very much. So we'll move on to the second session, and so I'll give this podium over to our very honorable Professor Akio Hyodo to say a short introduction and invite Professor Lee Wen for his lecture. Professor Hyodo.
Okay, thank you very much, Raja. This is my turn. And the second talk, I'm sorry, it's okay. Second talk is endovascular treatment of the cavernous sinus dural AVF. Will be presented by Professor Lee Wen from China. So, thank you very much, Professor Yoko Kato and Dr. Raja Kati. It is my great pleasure to chair the second session. And, everybody knows the dural AVF is acquired and progressive arteriovenous shunt disease on or between between the dural matter. And, the mainly located in the transverse sigmoid sinus and also cavernous sinus and the less anterochondral conference superficial sinus, and sometimes tentorial, anterocranial fossa, cranial subcranial, and also spinal dural matter. Today, Professor Lee Wen presented especially the cavernous sinus dural AVF and also the endovascular treatment. Recently, the first option is endovascular treatment. And so I expect very much. And also in China, there are a lot of population. And also, especially for the cavernous dural AVF is much frequently located in the China and also in Japan. It means it's a kind of Asian that we have a lot of cases. So Professor Lee Wen must have lots of cases to treat endovascular treatment of cavernous sinus dural AVF. So I expect very much. So, Lee Wen, are you ready for talk?
Yeah.
Okay.
Good afternoon, everyone. Good afternoon, everyone. I'm so sorry for delay. My name is Lee Wen. I'm a neurosurgeon. My hospital is the first affiliated hospital of Suzhou University. The topic of my lecture is endovascular treatment of the cavernous sinus dural arteriovenous fistula. My hospital is located on Suzhou City. There are small bridges, a floating house, a beautiful garden, and modern buildings. Suzhou integrating classical and modern. Welcome to Suzhou. Our hospital is a church hospital. Established in 1993. The Dot Park is the first D of our hospital. This is the old state of my hospital. The current our hospital. Now starting my lecture. Dural arteriovenous fistula is the cavernous sinus rare vascular stent involving meningeal branch and osseous branch of the external and internal carotid arteries and the CS. They typically present with the ocular symptom, including pain, conjunctival injection, and proptosis. cavernous sinus area dural arteriovenous fistula is abnormal traffic between the cavernous sinus and its nearby dural arteriovenous vein, also known as the cavernous sinus area. Arteriovenous malformation. The incidence of the CS DAVF is secondary only to the DAVF in the lateral sinus ring, accounting for about 30% of the intracranial DAVF. Now we talk about the cavernous sinus anatomy. The cavernous sinus isn't a single venous sinus, a venous plexure structure, but a venous space around the internal carotid artery, formed by the anastomosis of multiple veins and the venous sinus. The cavernous sinus has more complex venous branches and draining veins. The venous pathway of the cavernous sinus can be simply divided into the medial venous axis, intermediate venous axis, and the lateral venous axis. Bilateral cavernous sinus is connected with the intercavernous sinus and the basilar sinus. Look at this picture. The cavernous sinus, like the Central Park in Wujiaochang, Shanghai, and Xinjiang province, Gospel City. Cavernous sinus function communicated from all directions. The cavernous sinus is an important part of the radius circle of the venous system. In the arteries system, there is a radius circle. In the venous system, there have another radius circle. CS is the center of the communication between the deep and the superficial venous system. Now we talk about the anatomy of the DAVF artery in the cavernous sinus ring. Blood supply arteries, including ascending fascial arteries, femoral arteries, superior femoral artery branch, the posterior branch, medial artery, cavernous sinus branch, accessory medial artery, distal branch of the international maxillary artery, ophthalmic artery dural return branch. Draining veins include the superior ophthalmic vein, inferior ophthalmic vein, inferior petrosal sinus, deep superficial venous. CSDAVF classification, Thomas classification. Type 1 has the posterior and inferior drainage, superior petrosal sinus. Pterygoid plexus. Type 2 has posterior and inferior and anterior drainage, superior and inferior ophthalmic veins. Type 3 has anterior drain only. Type 4 has retrograde drainage into the cortical veins. Type 1 can lead to tinnitus. Type 2 and type 3 can lead congenital. Type 3 can lead to hemorrhage. Treatment selection procedure success depend on the identification of the venous outflows from the fistula. The location of the fistula is imagine the easily accessible part of the mechanical for the complicated mechanics. We must select the best route of the access to the CS. Access route to the CS in the vascular treatment, common access is IPS access. Rare access include transversal vein approach, superficial temporal vein to middle temporal vein approach, puncture facial vein approach. Trans-arterial access include transvaginal access in the superior vaginal branch and ascending vaginal artery. Trans-accessory meningeal approach and combined. Now we first talk about the treatment by venous common access, IPS access. Case 1, the female 48 years old, double vision, red eyelid, ptosis for 3 months. In the right ICA angiography, we can see the feeding artery is the medial facial trunk, bilateral, left and right and the left, medial facial trunk supply. The fistula is on the right side, and the fistula is on the side. We can see the IPS. We put the 5 French Navy in this and the micro catheters reach the CS. Hyperform balloon protect the ICA and we injection the onyx. After operation, the fistula disappear. The bilateral CCA, we can see the fistula disappear. IPS access case 2, female 48 years old, red eyelid, ptosis for 20 days. Right external carotid artery. We can see the CSDVF is supplied by the MMA and the internal maxillary artery. In right ICA, I can CSDVF is supplied by the medical file trunk. We can see the SOA. In the left angiography, we can see the CSDVF is supplied by the medical facial trunk of ICA. The fistula is located on the right CS. The left ECA, we can see the fistula is on the right. And the MMA and the internal maxillary artery supply. We put the micro catheters through the IPS to the CS. Injection onyx slowly. the fistula is large, and we only embolate part of the fistula. We continue to slowly inject onyx. Injection onyx until the fistula completely disappeared. Right CCA angiography. Treatment by the venous reconnect the access with the IPS. First case, female, 48 years old. Both air were red and swollen for 6 months. In left ICALP, and left ECA, we can see the fistula is located in left CS. We can see the SOV. The trace of the 0.035 inch guide wire on the road map imaging can serve as a guide for microcast shape select. We inject onyx. After operate bilateral CCA image, we can see the fistula will disappear. Transvenous approach is rarely seen. Facial vein, ophthalmic vein approach, and transsuperficial temporal vein, middle temporal vein approach. Transfacial vein, superior ophthalmic vein approach. Case 1, male, 52 years old, red eye red and swollen for 2 months. In the angiography, we can see the fistula in the left ICA. I can see the fistula is located in the right CS. 这个 medical facile of left ICA supply. In the lateral stand, we can see the SOV. The left ECA is normal. The frontal and the lateral image of the right ICA, I can medical facile trunk supply, and we can see the superior ophthalmic vein. I count the IPS isn't visible. IPS isn't visible. I can't see the IPS. We use the road map and the microcast test the CS. CS and projection of the red CS, but the CS has several compartments. The fistula doesn't involve the entire CS. No fistula was seen. We can see the right IPS intercranial sinus and left but I can't see the fistula. In the venous system, we can see the facial vein and the superficial temporal vein. We choose the facial vein system. We put the 5 French nervi in the facial vein, and the microcastus with the fistula and covering the fistula. This is the tapes of the 5 French nervi. We covering and injected the onyx. After operation, the fistula was disappeared. Left and right IC angiography. Transfacial vein super ophthalmic vein appearance female, 56 years old, left eye red and swollen for 6 months. In fistula was supplied by left ICA and ECA. Left ICA may go the facial trunk, and in the external carotid artery, MMA supplied. We can see the facial vein. French name is the types of the 5 French nervi this level. The microcatheter reach the fistula. Microcatheter reach the fistula and fill with the onyx. Positively imaging, we find that the fistula was disappeared. A transfacial vein, subcranial ophthalmic vein appearance, case 3, a female 63 years old, redness and swelling of the left eye for 2 months, aggravated for 1 month. In the left IC angiography, the blood supplied from the dural written branch of the ophthalmic artery. Ophthalmic artery written branch supplied the fistula. We can see the facial vein. First, we exploration of the IPS, and the microcatheter reach the IPS, but we can't see the fistula. So we choose facial vein. This is a bend. We choose the 5 French nervi and the 4 French MPA, because the nervis straight tips. The MPA have a better tips. So the slight face of the male vein easy to corner. The nervi should be selected to the facial vein. and the 5 French namely reach this level. And angulum 10 microcatheter reached the fistula and injection the onyx. After operation, the fistula is disappeared. Transsuperior temporal vein, middle temporal vein approach. Case 1 female, 54 years old, left emperor Salamos. We can't see the IPS, I can't see the IPS, but in the venous system, we can see the superficial temporal vein and the middle temporal vein. So we choose this approach. In this angiography, we can't see the IPS. We can't see the IPS. 5 French Navy must between the superficial temporal and the middle temporal vein, between this is bent. The 5 French Navy must reach this bend. And microcatheter forward in loop can reach the fistula. We injection the onyx immediately post-operative imaging the fistula is disappeared. After operation, left CCA, left LC, is normal. Case 2 female, 64 years, double vision for 2 months, and apparent conscious for 4 days. The right ICA is normal. The left ICA is normal. The left external carotid artery supplied the fistula. A bilateral fistula, left and right bilateral have fistulas. The left ECA, we can see the superior ophthalmic vein. The 5 French Navy reached the superficial temporal vein. In this case, superficial temporal vein is longer. Then the microcatheter forward in lobes reach the fistula and correlating. Road mapping shows a large fistula from here to there as a large fistula, holding the field entire fistula, and injection the onyx. The left fistula is occluded. The right fistula still emits onyx dispersed through the intercavernous sinus to the right. And the right fistula is occluded. Transarterial access, transphalangeal access via the superficial phalangeal branch of the phalangeal arteries. Transmiddle meningeal artery approach, transaccessory meningeal artery approach. We must the dangerous anastomosis. The ascending phalangeal artery approach is safety. Here is the anatomy with ICA lateral clinical artery. Agent anatomy with the ophthalmic artery. Case by female, 60 years old, with W redness and swelling of the left eye for 2 months. 2 months ago for positive access of the left eye. In CCA angiography, we find the fistula. The fistula is very small. Microcatheter this level. We angiography, we can see the fistula. We use the globin, 20% globin into the CS, After operation, the fistula is disappeared. We follow up the telephone for 2 years. Symptoms disappeared without recurrence. The patient refused to DSA review. Case 2, female, 77 years old, with a head hammer for 3 months, left eye red and swollen with the Cavernous city for 2 months. Angiography, we can see the fistula. Three dimension, we can see the fistula super funny. We put the microcatheter in this and reading in the supply artery. Onyx casting via the superficial phalangeal branch. After operation, we find the fistula is disappeared. Second, the middle meningeal artery. It is the largest branch of the maxillary arteries and originated direct from the first segment of the maxillary artery. The middle meningeal artery is the thickest branch of the maxillary artery and originated from the first segment of the maxillary artery. The middle meningeal artery entered the skull with the foramen spinosum and is divided into the anterior and posterior branch. The anterior branch gave it to the frontal and the parietal branch and the posterior branch give rise to the rhoncus branch, cavernous sinus branch, and the rhoncus scalp branch. Dangerous anatomies. Internal maxillary artery is dangerous because the anatomies with the ophthalmic artery. So the internal maxillary artery can't choose the approach. Case 1, the patient of 49-year-old woman was admitted to the hospital for car accident with cranial cerebral trauma for 3 months and swelling of the right eye for the more than 20 days. The diagnosis at the time of the accident was acute epidural hematoma of the right temporal area and the fracture of the right temporal bone. Examination, the right eye is contact with the conjunctival hemorrhage. The eyeball protrudes outward. In the right ICA, we can see the manifold facial trunk. And MMA supplied the fistula. In the external carotid artery, we can MMA supply the fistula. The microcatheter can reach this level. Roadmap, I can see the fistula. And we injection the onyx. Post-operative lateral position of the right ICA. I can the ophthalmic vein slowly. Lateral of the right external artery. For 6 days after surgery, we can't see the fistula. 1 year follow-up, I can't see the fistula. Another case, female 62 years old, admitted to the hospital on the 20th June with redness and swelling of the right eye with double vision for 2 weeks, aggravated for 3 weeks, 2 months. In the angiography, we can see the DAVF is supplied by the accessory meningeal artery and drained to the ophthalmic vein. Accessory we put the microcatheter to this level. It's very near to the fistula. Only small fistula. This is the small fistula. So we injection the onyx. Onyx dispersion very well. DAVF is obliterated. I imagine 5 minutes after the embolization, the fistula is disappeared. Preoperatively, 1 month after operation, now some files we talk about the complication, including technical complication, mainly in venous arterial venous approach, cranial nerve pulses, hemorrhage, ischemic complications, other complication, yearly decreased. My learn from through the experience, transvenous embolization of the dural and indirect CGF is a safe and effective technique, but it depends on the thorough understanding of the angial architecture of the fistula, including the arterial supply, venous outflows, and the fistula's point, and determine the optimal catheter approach and try the embolic agent. Now I talk about the hot topic, the target transverse venous embolization. This need the accurate positioning of the microcatheter. Fistula is limited to a small compartment of CS. Only embolize the fistula. My opinion, target transvenous embolization refer to the limitation of the fistula area. For the large fistula, targeted embolization will also block most of the cavernous sinus. Learn from the experience. Transvenous embolization of the DAVF is a safe and effective technique, but it depends on a thorough understanding of the angial architecture of the fistula, including the arterial supply, venous outflows, and fistula's points, and determine the optimal catheter. IPS approach is the commonly used approach, and blood exploration is accessible in most cases without visualization of the IPS. Transfacial vein approach and transsuperficial temporal vein approach are also suitable approaches. Selecting arterial access condition, I think the venous approach unsuccessful. Secondly, involves a single side dural of the CS. It is limited in size and with a few dural feeders. Third, microcatheter tip can be with into the fistula. No reflex during the manual angiography. We choose the anterior turn, no monsoon. The ascending frontal artery, MMA, and the accessory meningeal artery can provide a good approach to occlude the CSDVF. The decision of the endovascular access should be individualized according to the patient's specific anatomical characteristics. Thank you for your attention. Thank you.
Okay, thank you very much for your interesting presentation, Professor Li Wen. You showed a lot of cases and for the treatment of cavernous dural AVF by transvenous and sometimes transarterial approach. Maybe a lot of people have a question, and but I started to make a couple of questions. Is it okay? And you know, during the transvenous embolization, you prefer to use onyx directly. But I just afraid, you know, if the shunt is very, high shunt, I mean the first big shunt, I just afraid, the injected onyx pass through, deflected to the peripheral venous site. I prefer to combine with the coils and then some liquid embolus. So what do you think about that?
Yeah, I agree with you. I agree with you. In the past, in 10 years ago, I first chose the onyx. In recent years, I first chose the coils. Yeah.
And also,
we saw the first choice coils.
Okay.
Use the coils has the low complications.
And by the way, in Japan, the using the onyx in the cavernous sinus is prohibited because it's a kind of a trigeminal vagal reflex is very, very serious. So, are there any experience to have a trigeminal vagal reflex? You apply the onyx during the cavernous sinus?
Yeah.
Do you have any experience? Trigeminal vagal, due to DMSO, I mean.
Yeah. In my operator, I usually use the hyperformal balloon protect ICA.
Yes, protect ICA, it's okay, but the inside the cavernous sinus, there the many cranial nerves, especially for the trigeminal, some optic nerve, oculomotor or something. So there, some the stimulus by DMSO.
Yeah.
Any effect?
I have met a few cases.
Few cases. Okay. And also, I like to ask the transarterial using onyx, and especially from the ascending pharyngeal artery, they're very much the different anastomosis. For example, some cranial nerve also the between the internal carotid artery or something. So you showed a couple cases, but I think it's sometimes it's very dangerous. What do you think?
Yeah. I chose coiling in China. I must think about the press. In my price of the operation, we will think about.
Okay, I understand. Okay, are there any comments and questions from the audience?
So far, none. Professor Seba wants to say something?
Yes,
Thank you,
I
Professor.
think as the previous lecture by Dr. Aversa showed the power of surgery versus radiosurgery, which is very abused all over the world, I think this lecture shows the power of anatomy. The anatomy that medical students, residents, and younger surgeons have forgotten about. I think the anatomy of the cavernous sinus is so fascinating looking into the paper by Taptis, very 70 years ago, passing through Dollins and then Nifty and the others. The anatomy of the cavernous sinus is so unique that people need to master it. It is not no man's land. It is everybody's land now. So we need to know the anatomy there. And I also like to refer the young neurosurgeons and the residents to this beautiful paper by Roten called the dural arteries of the brain. Dural arteries is not only the meningeal and the recurrent meningeal, it is the ascending pharyngeal, the meningioacquisial, the inferior lateral trunk, and all these recurrent current ophthalmic artery and so on. So people need to know the dural arteries of the brain as much as they should know the venous side of the brain. And something always missed is the sphenoparietal sinus. People forgot about it. They don't know anything about it. This lecture shows the power of anatomy in either interventional radiology or in surgery. And just one question for the audience. How often do we need surgical closure of the AV fistula rather than interventional radiology? Anybody can give his opinion? What is the percentage of surgical treatment versus interventional treatment of a dural AV fistula?
Well, Professor Hyodo can answer that, Professor.
As for the cavernous sinus, I don't think it's a surgical intervention is useful. But for some other location, something like a spinal dural or anterocranial fossa, and the craniocerebral junction, it might be the good candidate for surgery.
So just to thank you again for the opportunity and for learning and discussing with you. It was a great honor to be here.
Okay, it's a time to conclude.
Yes.
Actually, today's second talk is endovascular treatment of the cavernous sinus dural AVF by Professor Lee Wen. I think it's very interesting, but it is not for all. Sometimes it's a very specialized doctor can do that. But for the treatment dural AVF, of course, mainstream is the endovascular treatment. But maybe the safe approach is using coil. But not only coil. Sometimes not we achieve the complete cure. So sometimes combined with liquid material, I think it's okay. So, but anyway, today's event, have a lot of cases to introduce us. It's very, very interesting. Thank you very much for Professor Lee Wen.
Thank you very much, Prof. Thank you very much. So with that, we'll conclude this session. I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Antonio Aversa, as well as Professor Lee Wen, and also the chairs, Professor Ibrahim Sabah and Professor Akio Hyodo, for the time and support for the ACNS webinars. I would like to express my sincere gratitude to Professor Shubin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host Liu Bun Seng for joining me today. So with that, I'll come to end of this webinar. Thank you very much for joining.